Right. Today we are going to talk about basic concepts related with the pneumothorax. Right. So first of all, what is pneumothorax? Every student knows pneumothorax is basically air in the pleural cavity or air or other gas in the pleural cavity. Is that right? Now, why it is so important to learn pneumothorax? Because once air is present in the pleural cavity, it may lead to the collapse of lung. Now I'm going to explain that how the presence of air leads to collapse of lung. It means how pneumothorax can lead to part of a lung collapse or total even collapse in some situations, right? So let's see that here you have your lung, right? And these are your airways. Let's suppose here is your, yes, what is it? Pleura. You know, lungs. Now, this part of the pleura is basically double layer. And outside, what should be there? Yes, chest wall. What should be here? Chest wall. And here are your intercostal muscles, right? Now, I will give you little basics before I go into detail. Now, of course, it's diaphragm. Now, what I want to put in your mind, that lungs are surrounded by a double layer of pleura, right? Now, one layer which is intimately attached with the lung parenchyma. This layer of pleura, which is attached with the lung parenchyma, pulmonary parenchyma, right? This is visceral pleura. What is it called? Yes, visceral pleura. And then there is other part of the pleura, the outer layer of the pleura, which is basically attached with the chest wall, right here, which is very strongly attached with the chest wall and diaphragm and even with the mediastinum, right? Now this layer of pleura, this is outer layer of pleura, and we call it parietal layer of pleura. So basically pleura consists of two layers: visceral pleura, which is attached with the lung parenchyma, and parietal pleura or outer pleura, which is attached with the thoracic cavity, right? Now, in between the two pleural layer, there is potential space. There is potential space. Potential space means in real sense there is no space, but space can be created. These two layers of pleura can be separated. So there is potential space with very little lubricating fluid. Normally, in a healthy person, the pleural cavity is the cavity between the visceral pleura and parietal pleura. It has about 10 ml to 15 ml or around 15 ml fluid on both sides pleural cavity, which is lubricating fluid. What is the function of that pleural cavity? What is the function of these two pleura, right? I will elaborate here. But before I explain, let me tell you that lung tissue has a tendency to collapse in. Lung is an elastic tissue. Lungs parenchyma has a lot of elastic tissue and it has a tendency to collapse in. So it means our lungs have, if I look at this part of the lung, it has a tendency to collapse in, or it has a tendency for recoiling in due to its elastic recoil. It's right. In the same way, our chest wall, it has a tendency to recoil outward. It has a tendency to recoil outward, right? Now, lungs have a tendency to shrink inward or bounce inward, and chest wall has a tendency to bounce outward. But both these lungs and the chest wall, they are held together. They are held together due to stickiness of these two pleural layer. Visceral pleural layer and parietal pleural layer, they are sticky to each other. They can glide on each other. They can normally glide or slide on each other, right? I mean, if we consider that this is, here is your lung, here is your chest wall. Now this is my which pleura? Visceral. And what is this pleura? Parietal. Now visceral and parietal pleura, they are sticky. They are having some sticky fluid, lubricating fluid. They can glide on each other, but in healthy situation they cannot separate. But because lungs are all the time trying to collapse in or recoil in, and lungs and chest wall is all the time trying to recoil out. So due to this reason, as both lungs tendency to recoil in, chest wall tendency to recoil out, so it creates negative intrapleural pressure. What it creates? Negative intrapleural pressure. It means pressure in between the two layers of pleura is negative, subatmospheric, right? In a healthy person, most of the time, in a healthy person during normal breathing, intrapleural pressure is always negative, because lungs will love to move in and chest wall will love to move out, but stickiness of them is keeping them together. Is that clear? Any question up to this? Now this negative intrapleural pressure, this negative intrapleural pressure which is created here, what is this? Negative intrapleural pressure. Lungs love this pressure. Lungs love this pressure. Why? Because this pressure keeps the lungs expanded. If you finish this pressure, lungs will collapse in. And if lungs collapse in, can they do their ventilatory and other functions properly? No. For proper function of the lungs should be appropriately inflated. And to keep the lungs inflated, right, pleural cavity must have negative pressure, intrapleural pressure, so lungs remain expanded. I will explain it with an example also. Let's suppose there is a glass slide. This is which layer? Visceral. And what is this? Parietal. And I put them together as two slides. You know, in the laboratory you see the glass slides. Now, this is behaving as parietal pleura, which is trying to go outward. It is attached with the chest wall, which has a pull outward. And this is behaving as visceral pleura, which is trying to pull this inward. Now you imagine these two pleural layers. From here I put it here. They are like glass slides which we use in the pathology lab or histology lab, and they are wet. And they are wet. When two glass slides are wet, they are sticky to each other. They are sticky to each other. Is that right? And if you slightly pull on the other sides, there will be some negative pressure created here. Is that right? But they can glide on each other, they can slide on each other, but they cannot fall apart if you don't put too much pressure. Is that right? Now, if by some mechanism you introduce air here, a little air, if you put a little air, do you think they will stay together? They will separate. When they will separate, it will bounce outward and other part will bounce inward, and a cavity, true cavity with air is produced in between the two pleural layers. Is that clear? So what is happening, that once air enters into pleural cavity, Once air enters into pleural cavity, like these two sticky slides, two layers of pleura fall away, and that part of the chest wall will bulge outward, and that adjacent lung with that chest wall will recoil inward. So chest wall and lungs will be separated. And once they are separated, during inspiration or expiration, as you move the chest wall, will lung move with that? No. And lung will lose its ventilatory functions. Lungs will lose their ventilatory function. Is that clear?
Yes.
So up to now I have only explained what is pneumothorax. Pneumothorax is presence of the air or other gas in the pleural cavity. And I explained that once air enters there, what will happen? Two layers of the pleural cavity will fall apart, right? It means negative intrapleural pressure will be lost. Negative, once you introduce the air, negative intrapleural pressure will be lost, right? Or reduced. And when two layers are separated, chest will bulge outward and lungs will collapse, or part of the lung will collapse inward. Is that clear? So this is what happens in pneumothorax. But the question is that from where the air comes? Question is from where the air enters into pleural cavity. Very simple. Either air will come from, normally air is present in the lung, parenchyma, in the alveolar conducting and alveolar system, respiratory system. So either air can enter from, what is this side? From the lungs, or air may enter from the chest wall. Right? Now we're going to detail what are the causes of pneumothorax. We just discussed what is pneumothorax, and we discussed what happens to lungs and chest wall if air enters into pleural cavity. And I said air can either come from the lungs or it can come from the chest wall. Now we will go into detail that what are the causes of entry of air into pleura, right? According to that, pneumothorax, according to the cause of that how air enters in the pleural cavity, it is basically classified into spontaneous pneumothorax and traumatic pneumothorax. So now I will go into detail that what is spontaneous pneumothorax and what is traumatic pneumothorax. First of all, you should know the difference between what is the real difference between spontaneous pneumothorax and traumatic pneumothorax. Spontaneous pneumothorax is where a person develops suddenly pneumothorax without any recent trauma, without any antecedent trauma, without any warning. I'm just standing here and I may develop pneumothorax. Right? If you develop pneumothorax suddenly without any antecedent trauma or any warning, such pneumothorax is called spontaneous pneumothorax. Or very simply, spontaneous pneumothorax is the pneumothorax which occurs spontaneously. What is spontaneous pneumothorax? Spontaneous pneumothorax is when pneumothorax occurs spontaneously. It means without any precipitating cause there, without any trauma, without any antecedent event. So, but traumatic pneumothorax is when air enters into pleural cavity, either there is trauma to the chest wall or trauma to the lung tissue. So if entrance of air is after the trauma or due to the trauma to the chest wall or to the lung, then we say this pneumothorax is traumatic pneumothorax. So the real difference between spontaneous pneumothorax is spontaneous pneumothorax occurs without trauma, and traumatic pneumothorax occurs due to trauma. Now, spontaneous pneumothorax is further divided into two types. Spontaneous pneumothorax, that is primary spontaneous pneumothorax, right? And there is secondary spontaneous pneumothorax. Again, first of all, once the air is present in the pleura, it is pneumothorax. Then you have to see in the history. Was entry of the air due to some trauma? Then it is, if it is due to trauma, then it is traumatic pneumothorax. And if it is without trauma, then it is spontaneous pneumothorax. Spontaneous pneumothorax is divided into two types of situation. One group of patient in which pneumothorax occurs spontaneously without any significant underlying pulmonary disease. For example, this is my patient, right? This patient suddenly developed pneumothorax and there is no underlying lung disease. There is no underlying lung disease. We say it is primary spontaneous pneumothorax or idiopathic. It was previously considered idiopathic spontaneous pneumothorax. And then I talk about second patient. In this patient, what happens? Even though pneumothorax occurred spontaneously, but there is already some serious disease in the lung. There is some significant pathology in the lung, and that pathology lead to spontaneous pneumothorax. It means that pathology led to the pneumothorax formation, but there is no trauma. Underlying lung pathology is there. Such kind of spontaneous pneumothorax is said to be secondary spontaneous pneumothorax. So we can say, if in the case of pneumothorax, let me draw a pneumothorax here. And here is your lung. And air is here. Let's suppose this is the air. Now, if someone has air in pleural cavity and it suddenly came, it is spontaneous, and there is no significant underlying lung disease, right? Then we will call it primary spontaneous pneumothorax. And if there was some underlying pathology in the lung and that pathology led to the entry of the air here, but suddenly without any trauma here, right? Without any injury here, just pathological process in the lung led to the leakage of air here. Then it is also spontaneous but secondary to a pulmonary disease, right? Now, what are the patients in which primary spontaneous pneumothorax occur? Usually these are young males. More commonly, it can occur in females but less commonly. Primary spontaneous pneumothorax is most commonly seen in young males around age of, you can say, teenagers, or usually less than 30, right? And yes, they are thin, tall, young males, and usually smokers. Smoking enhances the risk of primary spontaneous pneumothorax. Now, question is that why in young, thin, tall, young males spontaneous primary pneumothorax occur? Someone apparently very young and very healthy, right? No underlying lung disease, right? Nothing diagnosed or no underlying lung disease, but suddenly pneumothorax developed. Because initially doctors never knew the cause, they just called it idiopathic spontaneous pneumothorax. But now we know what is the cause. Actually, in some young people, pleura, this is which layer of pleura? Visceral layer, right? And here is parietal layer. sometimes what happens, visceral, there is air bubble or air present just under the, okay, air is present here. This is subpleural air bubble. We call it bleb. What we call it? Pulmonary bleb. It is pulmonary bleb. So what actually many young, tall, thin males may have multiple subpleural blebs. What are these blebs? These are air pockets which are between the lung parenchyma and the visceral pleura, or sometimes in between the two layers of visceral pleura. In that case, we call it intrapleural bleb. So there may be subpleural bleb, or if it is like that, then it is intrapleural bleb. Now these are multiple blebs in usually young, thin, tall males, and sometimes they rupture. And when this bleb will rupture, of course, air will leak into pleural cavity, and air will leak into pleural cavity, right? So what is the underlying cause of primary spontaneous pneumothorax? I will say the presence of subpleural or intrapleural blebs which are under the or in the visceral pleura, not parietal, under the visceral pleura. Usually these blebs are multiple. Due to this reason, these patients who are diagnosed with primary spontaneous pneumothorax, these patients have a high tendency of recurrence, right? Because maybe today one bleb is ruptured, after 6 months another bleb rupture, after 3 years another bleb ruptures. You're getting it? Depending on how many blebs are there, right? So is that clear? Yes. Now another term which is used, these are pleural blebs. Another term is used, pulmonary bulla. Have you heard of it? Pulmonary bulla. What is the difference between bleb and bulla? I put it here, pleural blebs or pulmonary bulla. Both are air-filled spaces. Both can lead to pneumothorax. But there is significant difference. The difference is, if this is the lung, this is your which layer? Visceral. If air is trapped here, okay, I show. If air bubbles are trapped here, what is this? Subpleural bleb. Or if there is a little visceral pleura here also, it is intrapleural bleb. Now, how it is different from pulmonary bulla? In the pulmonary bulla, actually there is a big air-filled cavity, right? But point to be noted is that this is air containing space, most commonly seen in patients with emphysema. Here, actually, this air bubble is surrounded on all sides from the lung parenchyma, right? Here, on one side there is lung parenchyma, and on other side there is visceral pleura. You understand the difference? So pulmonary bullas are large air spaces which may be present subpleurally, but they are all from air is throughout surrounded by lung parenchyma. In bleb, it may be subpleural or intrapleural, right? And if it is subpleural, then on one side it is surrounded by the visceral pleura, another side it is surrounded by the lung parenchyma. Am I clear? Now we come to secondary spontaneous pneumothorax. What is secondary spontaneous pneumothorax? We'll go back to our discussion. Let's suppose here is your beautiful lung, and here are your air space, it's a simplified diagram, and here is your visceral pleura, and here is on mediastinal pleura on this side, diaphragmatic pleura, and other part of the pleura, which is parietal pleura. This is the outer pleura. Now, sometimes air escape into pleural cavity from the lungs due to some underlying pathology in the lung. Here there was no significant pathology, just there were blebs. But in this case, where air suddenly come into pleural cavity, because it comes suddenly without any antecedent trauma, we say it is spontaneous. But this spontaneous event, spontaneous entry of air is associated with underlying significant pulmonary pathology. So we call it secondary spontaneous pneumothorax. Now question is that how the air can reach from the lung to the pleura. One thing is very simple, that air may leak into, maybe there is some pathology, and due to that pathology, air space is just under the pleura, and subpleural rupture of air space, and air enters from here. I will talk about the causes later. Right? This is one way. It is direct entry of air from the subpleural pathology into pleural cavity. Other is that sometimes air leak into interstitium of the lung. This is lung parenchyma or interstitium. From here, air moves proximally to the mediastinum. So it means air leaked into lung parenchyma, then moved to, it dissected through the lung interstitium, and then it went into mediastinum, right? And through the mediastinum, it may produce a rupture in, what is this? Parietal pleura, and may enter here. Or it may go towards the neck, and this air may escape into subcutaneous tissue. We call it subcutaneous emphysema. Have you heard of it? Which produces crepitus. So what happens? What I'm trying to tell you, that if there is significant pathology in the lung, due to this pathology, air from the pulmonary air spaces may enter directly into pleura, right? Or it may take an interstitial route, and through the interstitium, either it goes to mediastinum, producing mediastinal emphysema, and then it may produce a rupture in the pleura and may produce pneumothorax, or even it may go upward into neck and root of the neck and subcutaneous tissue and produce subcutaneous emphysema. You are understanding? Now, what could be the underlying pathologies which can lead to this kind of pneumothorax, right? What could be the underlying causes? Once I finish these causes, ask me what are the classical features of spontaneous pneumothorax, right? Now, what could be the causes? One thing very simple. If due to any reason, I will enlarge this here, right? Now I'm going to explain the mechanism of This is the airways, and here are, let's suppose, other distal air spaces. It's a simplified diagram. Now, what could be the different diseases of lungs which can lead to spontaneous secondary pneumothorax? Answer is almost every lung disease. But still, I will stress on the more common. First of all, first group of diseases is obstructive lung diseases. What are they? Obstructive lung diseases. Now, obstructive lung diseases are those lung diseases in which there is increased resistance to the airflow through the air passages. Obstructive lung diseases that when air is moving through the air passages, there is increased resistance. There is some degree of pathological obstruction faced by the air to flow through airways during inspiration and expiration. Is that right? Then we call, now if this kind of obstruction is there in the airways, we call it obstructive lung disease. Right? Usually, generally speaking, obstruction is more pronounced during expiration and less pronounced during inspiration. In obstructive lung diseases, during inspiration, degree of obstruction is less. And during expiration, degree of obstruction is more. What I'm trying to say, that generally speaking, in obstructive lung diseases, for air to enter in is relatively easy, but to get out is relatively more difficult. I mean, this is something that you can get in, but you cannot get out. There are many situations in life like that. You get into a relationship sometimes, but you cannot get out. Or there's more resistance. You happily entered in inspiration, but to get out of the relationship, sometimes there is unusual obstruction. Now, question is, before I go into really detail and all these causes, I must explain why in obstructive lung diseases there is more resistance to the airflow during expiration and why there is less resistance during inspiration. To explain that, I will go to normal lung, how the normal lungs behave, right? During inspiration and expiration, right? Let's suppose this is your normal lung, healthy lung, alhamdulillah, and these are the airways, right? Okay, I will make these black. These are distal air spaces, right? These are all air spaces. And they are all around. Is that right? Yes. This is lung parenchyma. Now, as I told you previously, that lungs have lot of elastic tissue. So they love to recoil. Lungs normally love to recoil. But normally in a healthy person, lungs are kept inflated due to negative intrapleural pressure. Is that right? Now imagine, this is your pleural which layer? And this is parietal. When chest wall is expanding, during inspiration, chest wall is pulling the visceral layer outward, that is pulling the lung outward. In the same way, diaphragm. So what happens, that lung is, during inspiration, lungs are being pulled from everywhere outward for expansion. Lungs are being pulled outward. when they're being pulled outward, this airway, suppose this airway, lung is being pulled there and pulled here. What will happen to this airway? Open. Open. So during inspiration, what happens? When whole lung is expanding, there is a peripheral traction of the elastic lung tissue on the airways as well. And airways are also expanded, right? Let me make a section from here, this airway, right? If I make a section here, this airway I put, this is the airway, this point, right? And this point. This is the airway. And here are, what are these? Your lungs, different spaces. Is that right? Now during inspiration, now listen carefully. During inspiration, when lung is expanding, you are understanding? When it is expanding, there is traction on what? Airway, right? Or we can make a part of a lung like that. I make a section of lung here. This is airway, right? And then it is dividing into, let's suppose, air spaces, right? Now actually, all this is surrounding by lung parenchyma. You understand it? When lungs are expanding, it means the whole lung parenchyma is expanding. Lung whole parenchyma. So this, all the lung parenchyma which is surrounding what? This airway, that is also pulling the airway outward, all walls. So airway will become open. This is what happens normally during inspiration. There is that during inspiration, to already open airways, there is, as lungs are expanding, elastic pull of the lung tissue has added traction, radial traction on the airways. So during inspiration, they become more wide open and inspiration is relatively easy. Now, in a healthy person first, during expiration, what happens? In a healthy person, when expiration is occurring, lung is getting smaller. When lungs are getting smaller, the traction on the airways by the pulmonary substance is increased or decreased? Decreased. When traction is decreased, they become relatively smaller. So in a normal healthy person, during inspiration, airways are relatively wide, more open, and in a normal healthy person, during expiration, airways are relatively narrow. But this little narrowness does not produce any pathology in a healthy person. Is that right? Now you imagine, if there is some obstructive disease, let's suppose there is some obstructive disease and due to that reason, there is some obstruction here. So airways permanently smaller. Now during inspiration, airway will still open due to traction around it. But during expiration, it may become very, very narrow. Your understanding? Yes. Again, I will repeat. If there is obstructive airway disease, let's suppose there is some obstruction to this point, right? Now, okay, leave a little opening at least. Now there's a little opening here. When this person will do inspiration, as lung tissue will expand, it will radially open the airways. So during inspiration, it open a little more and there is less resistance to the airflow. There is resistance, but less. But when this person do expiration, when lungs are getting smaller, airways are no more pulled radially outward, so they also become further small. And because there was pre-existing obstruction at the top, during expiration, the airways become smaller. So for outward flow become too much restricted. Are you understanding?
Yes.
Or I'm just teaching myself? You got it?
Yes.
So I will repeat what I said up to now. First of all, I said airways are not static, they are dynamic. During inspiration, they open, and during expiration they become little narrow. In a healthy person, during inspiration and expiration, in both situations, in a healthy person, airways are open, but they're more open during inspiration and less open during expiration. Why normally they're more open during inspiration? Due to radial traction of elastic tissue. When lungs are expanding, all the airways open. And during expiration, when traction on the airways from the periphery is less, so elastic recoil of airway wall little bit narrow the airways. Is that right? Then I came to this thing. If in the airway there is already obstruction, if there is some obstructive disease, right? If there is some obstructive disease, that during inspiration airway may open a little bit, and inspiration may lead to some inflow of the air. But during expiration, airway become pathologically too much narrow, and there's more difficulty in getting the air out. Again, in obstructive lung diseases, obstruction during inspiration is less pronounced, and during expiration it is more pronounced. So usually in obstructive lung diseases, the main problem is not how to get the air in. The more serious problem is usually with exceptions, usually how to get the air out. It means during inspiration you take the air in, and during expiration less air come out. During inspiration you take more air in, during expiration you take less air out. Progressively you accumulate the air, and lungs become bigger and chest become barrel shaped in obstructive lung diseases. Any question up to this? No. Here I want to tell another thing. Okay, come over here. What are obstructive lung diseases? Who will tell me? Okay, doctor. Just name the obstructive lung diseases. You are about to impress me. Yes, please. Emphysema, very good. Emphysema. This produces obstruction. I will explain how. Then there is chronic. Very good. Bronchitis. Then asthma. Then bronchiectasis. Now these are common obstructive lung diseases, right? There are some other also. I will not go into detail of those. Now obstructive lung diseases, the lung diseases in which there is obstruction to the airflow, especially more pronounced during expiration, is seen in patient with emphysema, patient with chronic bronchitis, patient with asthma, and patient with bronchiectasis, right? And there is a term very commonly used, chronic COPD. Have you heard of this? There's a term called COPD, chronic obstructive pulmonary diseases. Very good. What is the difference in obstructive lung diseases and COPD? Question goes to any young man. Raise your hand. Who can tell me the difference between obstructive lung diseases and COPD? It means I'm asking about what is the difference between obstructive lung diseases and chronic obstructive pulmonary diseases. Yeah. Yes, he is saying it's the same. And all of you must know he is wrong. He is wrong. All obstructive lung diseases are not the part of COPD. This is very important to understand. Many doctors get confused about it. There are so many diseases which produce obstruction to the airflow in the lung, but all of them are not COPD. All of them are not chronic obstructive pulmonary diseases. When we talk about chronic obstructive pulmonary diseases, basically we are talking about these two. Classically speaking, typically speaking, these two are COPD. So I can say, I can classify it like this also. Obstructive lung diseases are COPD, asthma, and bronchiectasis. Another better way for understanding, obstructive lung diseases are COPDs, asthma, bronchiectasis. And COPD mainly include emphysema and chronic bronchitis. Is that right? And all these diseases, because they produce some degree of obstruction, right? Because they are producing some degree of obstruction, what happens? During inspiration, let's suppose, okay, we talk about this situation. There is obstruction here, right? Obstruction. Now, in these cases, air will, during inspiration, will get into airways and air spaces, right? Air will enter. But during expiration, all of it is not going out. So pressure in the alveoli will go up or down? It will be up. It's very simple. That when there are obstructive lung diseases, regardless of its emphysema or chronic bronchitis or asthma or bronchiectasis, whatever kind of obstructive lung diseases, right? Because there is more obstruction during expiration, so air is trapped here. Air is trapped here, but wall of alveoli, now pressure in the alveolar space is increasing, right? In obstructive lung diseases, when air traps and pressure in these air pockets increases, when pressure in these air pockets increases, alveoli are very delicate walls. They may rupture. They may rupture. And if they rupture just under the pleura, then there will be direct entry of air into pleura. Now you understand how a patient with obstructive lung disease has predisposition for pneumothorax. Why? Because these patients have, number one, higher pressure in the alveoli, and some of the alveoli really become high pressured in obstructive lung diseases, and the delicate walls of the alveoli may rupture. And if it is just subpleurally, air will escape into pleura and produce pneumothorax. Or alveolar rupture, where? In the interstitium, delicate walls. When alveolar rupture, air which was under pressure will enter into interstitium, and this interstitial air will track, as I mentioned previously, and eventually enter into pleural cavity. So either there is subpleural leakage of air from the alveolar spaces, or there is interstitial leakage of alveolar air, right? And then interstitial area is dissected by the air, and this dissection may move proximally towards the mediastinum, as I mentioned previously, and eventually it may rupture the pleura and produce pneumothorax. So is it clear that how obstructive lung diseases can predispose a person to pneumothorax? This pneumothorax may occur without trauma. There is no one is putting the knife in your chest. There is already pathology in the lung, and that pathology precipitated this secondary spontaneous pneumothorax. Am I clear?
Yes, sir.
Anyone who is confused? Very good. Here I want to mention one thing. When we talk about that airway obstruction, especially airway obstruction, it's very clear. In chronic bronchitis, underlying pathology is that airway has hyperplasia of mucous glands in chronic obstruction, and there are more secretions. Again, I will repeat. Let's suppose here you have airway cross section, right? These are the mucus. What are these? Mucous glands, right? These are the blood vessels, right? And here are what is this? Smooth muscles. What are these? Smooth muscles. Now this is the lumen. What is this? This is the lumen. Now imagine, I will talk about emphysema later. In chronic bronchitis, what is the underlying problem? Even though it is diagnosed clinically that there is persistent cough more than 3 months with sputum production, may or may not be, but with sputum production more than 3 months in 2 consecutive years without any other explanation of the clinical features, right? But I will not go into detail. We will have a full lecture on chronic bronchitis, thorough detail. For a while I will just mention in chronic bronchitis what really happens, that these secretory glands become hyperplastic and there are more secretions, and if they are producing more secretions, it means there is intraluminal obstruction in chronic bronchitis due to increased secretion. Plus in chronic bronchitis there is inflammation of bronchial wall, and this swells inward. When it swells inward, further reduces the lumen. So in chronic bronchitis, obstruction is due to luminal increased secretions and also due to inflammation of airway walls, bronchial walls. Clear? In asthma, what happens? There are three components. One, increased secretions. Number two, inflammation of the wall and swelling and edema, plus constriction of bronchoconstriction. Episodic reversible bronchoconstriction. All these things can lead to obstruction. So this can lead to obstructive situation. This can lead to obstructive situation. Later on, we'll discuss in detail in bronchiectasis what happens. They are necrotizing inflammations, necrotizing inflammation of the wall of, what is this? Bronchi, which lead to destruction of cartilages and smooth muscles and other components of the bronchial wall. And at places, bronchial walls pathologically and irreversibly dilate. But because they have increased secretions also, let me make airway with bronchiectasis. This is airway. It has one pocket here and one pocket here and one pocket here, like that. Now what happens in this area? There was necrotizing inflammation which destroyed the elastic tissue and sportive component of the bronchial wall so much that it become very weak, and due to air pressure it bulge out. So these are, you can say, permanently irreversibly dilated areas of airway. This is bronchiectasis. But you need to remember that inflammation is not only in these pockets. Inflammation is in between that too. You are understanding? So whole lining of bronchial tree is inflamed in bronchiectasis. Multiple areas are inflamed, and if this area is inflamed and there is infection and secretions, it will become obstructed. So what I'm saying, that chronic bronchitis, it leads to what? Obstruction due to increased secretions and inflammation and edema of airway walls. Asthma, obstruction due to increased secretions, swelling and edema, inflammation and bronchoconstriction, smooth muscle restriction, and bronchiectasis also has obstruction due to increased secretions and inflammations. Is that right? The real master understanding is needed to understand why in emphysema airways become obstructed. Because emphysema is a disease related with distal air spaces. Emphysema is a disease related with distal air spaces. So what really happens in emphysema, that air spaces become enlarged, alveolar air spaces become enlarged, and their septa are destroyed. This is the basic pathology, right? Again, let me explain. This is, let's suppose, I'm just showing part of a lung. Which is having emphysema. Now, what is happening? These are the normal Now you see, what is happening? Actually, in emphysema, these septa, these are destroyed, right? Due to inflammation. We'll have a full lecture on emphysema. For a while, you just trust me. That what really happens in emphysema, these septa, these are destroyed by different proteolytic enzymes and collagenases and elastases which are released by neutrophils and other mechanisms. When they are destroyed, what will happen? That it will become like that. I mean, air space will become like this, and this component is lost. Here also, if air space was like that, this component is destroyed. Intraalveolar septa are destroyed, and if they are destroyed, then it will also become like this. Here also they are destroyed, become like that. So what really happens in emphysema? That interalveolar septa are destroyed. And when they are digested away and destroyed, distal air spaces will become smaller or larger? Of course, larger, right? But these septa have elastic tissue. It means if there is widespread emphysema of the whole lung, if both lungs undergo widespread emphysema, it means millions and millions of interalveolar septa are destroyed. Millions and millions of interalveolar septa are destroyed. If they are destroyed, it means actually lung elastic tissue is destroyed. What does it mean? Lungs elastic tissue is destroyed. And when lungs elastic tissue become destroyed, lungs become tight or they become loose. Okay, just imagine you have a rubber band. And in a rubber band, if elastic tissue is destroyed, then it will recoil strongly or it will recoil weakly? It will recoil weakly. Are you understanding what I'm saying? That again, in the lungs, elastic tissue is destroyed because interalveolar septa are destroyed. So lungs' tendency to collapse is less or more? Less. What really happens? Air spaces become large. Okay, I will show you here also emphysematous changes. So this also become like this, this, and this. Septa are lost. Now you imagine that if this is an airway, around it there are all air spaces. If all air spaces have lost their septa, then their ability to keep the airway open, radial pull, is increased or decreased? Decreased. This is what happens in emphysema. That in patients with emphysema, even though patient with pure emphysema, there may not be pathology, significant pathology in the airway itself. Pathology is in the alveolar area. But due to loss of interalveolar septa, or we can say due to loss of elastic tissue in the lungs, the radial traction on the airway is reduced. So patient with emphysema lungs have big lungs but narrow airways. Are you understanding? Yes. They have big lungs, overinflated lungs, hyperinflated lungs, dilated air spaces, but because airways cannot be having a traction outward, so what really happens that this elastic tissue which was previously very tight, now it becomes loose because there is less elastic tissue, so it cannot keep it open. So during inspiration air may go somewhat, but during expiration it can come out easily? No. So this is a mechanism of obstruction in patient with emphysema. So if someone asked you in emphysema, in patient with pure emphysema, because many patients have a combination of features of emphysema and chronic bronchitis, because both of them are associated with smoking, strongly associated with smoking. But if you end up with a patient with emphysema, pure emphysema, then what will happen? That distal airways, distal air spaces or interalveolar septa are destroyed. It means collagenases and elastases have been very active, and when elastic tissue of the lung is destroyed, lungs have less tendency to recoil, and even during even the normal radial traction on the airways by the surrounding lung tissue, that is also reduced. So airways become narrow. So during inspiration there is resistance to the flow but less, but during expiration there is pronounced obstruction. Right? You are understanding? And you are understanding it or not? Clear? Okay. Any question up to this? Right? So these are obstructive lung diseases like emphysema, chronic bronchitis, asthma, bronchiectasis, and other obstructive lung diseases. They can lead to emphysema, can lead to pneumothorax either by release of air directly from subpleural rupture of the alveoli, or rupture of alveoli due to high pressure in interstitium, and then air moves through the interstitium into the mediastinum and then it may rupture. Any question up to this? So now you are very clear, hopefully, that patient who have obstructive lung diseases, right? They have a higher risk of pneumothorax, spontaneous pneumothorax. And this spontaneous pneumothorax must be considered secondary pneumothorax. Then another group of diseases of lungs, that is destructive and cavitary lesions of the lung, pathologies. Already we have discussed lung diseases, obstructive lung diseases, in which two of them are COPD. But there can be other underlying pathologies. They can also produce spontaneous secondary emphysema. Yes, pneumothorax. Spontaneous secondary pneumothorax. What could be the other causes? Other causes may be, yes, I told what could be those causes. That is destructive and cavitary lesion, cavitary pathologies in the lung. Now, how destructive? Okay, let me put it here. Obstructive lung diseases and destructive and cavitary lung diseases. They can also produce secondary spontaneous pneumothorax. They can also produce secondary spontaneous pneumothorax. Thanks God, it is easier to understand than this one. Let me make a diagram. This is the suppose airway, right? These are your distal air spaces, right? In the same way here we can put also air spaces. Now, if there is destructive lesion, for example, there is lung abscess, and what is here? This is your which pleura? Vestral. And there? Parietal. Now imagine, if there is some destructive lung disease, for example, there is a lung abscess here. There is lung abscess here. Now it destroys this tissue, right? On one side it has airway, on other side it is just under the pleura. It's so easy to understand. If this abscess ruptures and drain into what? Pleura, then air can move from, what is this? Bronchus, from the airway passing through the pathological tissues opening and directly opening into pleural cavity. Because this pathological process which is destroying the lung parenchyma, on one side it was having airway, on other side it was just subpleurally situated. It was situated just under the pleura. If this destructive or cavitary lesion breaks away, then air from the bronchial tree can directly enter into pleura and produce pneumothorax. Is it clear? Another thing can happen, that let's suppose that this cavitary lesion is here or destructive lesion is here, right? And it undergo necrosis. On one side it is connected with the airway, other side it is lung interstitium. So it is possible when it melt away, the air from the bronchial tree may enter into interstitium of the lung, and then the same route. From the interstitium it may go dissect and eventually reach to pleura and produce pneumothorax. So this is the mechanism in which destructive and cavitary diseases of lungs increases the risk of secondary spontaneous pneumothorax. Clear? Now, what are the examples of this condition? Of course, at the top, I would love to put tuberculosis. because tuberculosis not only produces caseous necrosis, but it also produces cavitary lesions. So in patient with tuberculosis, there is a risk of pneumothorax. Is that right? Then suppurative pneumonias. Pneumonias are the infections of lung parenchyma. And if there is very aggressive pathogen, right? For example, Staphylococcus aureus or Klebsiella pneumoniae, right? Right? So very aggressive organism. Or even in patient with HIV, pneumocystis pneumonia. Is that right? Pneumocystis pneumonia is more commonly seen in patients which are immunocompromised, right? That is opportunistic organism, pneumocystis. Now, any pneumonia which is very aggressive, it may be bacterial or it may be fungal or any kind of pneumonia. If it produces destructive lesions and eventually cavitary lesions, it increases the risk of secondary spontaneous pneumothorax, specially mentioned PCP, pneumocystis pneumonia, right? Classically seen in patient with severe immunocompromised situation like HIV and AIDS. Then, yes, what else you can tell me about? Cystic fibrosis. I have a full lecture already recorded on that. Then you can come, yes. Pulmonary infarctions. If there's pulmonary infarction and infarcted area necrotizes, you are understanding? On one end there is airway and other end there is pleural area. Air may leak into pleural area. So again, severe pulmonary infarcted area is a destructive area, destroyed area. So what happens? Either tuberculosis destruction or other severe infections. Classically lung abscess, of course I should mention here, lung abscess. It can drain into pleura and then also connect the bronchus with the pleura. If pleura and bronchus, if bronchus and pleura, they are connected and air can coming from bronchial tree to the pleura, we also call this condition this is bronchus, bronchopleural fistula. What is it called? Bronchopleural fistula, right? So many cavitative or destructive lesions may produce bronchopleural fistulas. So we are talking about lung abscess, tuberculosis, pneumonia, pneumocystis carni pneumonia. No, pneumocystis pneumonia, its name is changed now. Cystic fibrosis, pulmonary infarction, then yes, carcinoma. Pulmonary carcinoma. Which carcinoma, which lung cancer has a high chance of cavitary lesion? Squamous cell carcinoma. Squamous cell carcinoma, usually these are central lesions. They achieve a bigger mass and then in the center they undergo necrosis and cavitation, right? Squamous cell carcinoma. And even though it is centrally located lesion, squamous cell carcinoma, but this cavitary lesion may connect the pleura and airways and may lead to what? Secondary pneumothorax. So what we have talked about, TB and suppurative pneumonia, pneumocystis pneumonia, lung abscess, cystic fibrosis, carcinoma, infarctions, right? All these can lead to spontaneous, secondary spontaneous pneumothorax. Is that right? Now, we have just discussed what is pneumothorax. Up to now, what is pneumothorax? Just presence of air in the pleural cavity or other gas in the pleural cavity. What happens due to presence of pneumothorax? Two layers of the pleura separate from each other. Chest bounces out and lungs bounces in and collapse, and ventilatory functions of lungs are impaired. Is that right? Why pneumothorax occur? It may be spontaneous or it may be due to some trauma. We have not discussed traumatic pneumothorax up to now. Even we have not discussed the type of pneumothorax. I was just concentrating that spontaneous pneumothorax and its detail. It may be primary or it may be secondary. Spontaneous pneumothorax is pneumothorax which occurs suddenly without any antecedent trauma, right? Or any warning. In primary spontaneous pneumothorax seen in thin, tall, young males, more often smokers, right? Due to subpleural blebs, which rupture, because usually these patients have multiple blebs, so there's a high rate of recurrence, right? And you must know the difference between pulmonary bleb and pulmonary bulla, right? Bleb is partly surrounded by pleura and partly surrounded, maybe partly surrounded by the lung parenchyma. But bulla is large air space surrounded on all sides by the lung parenchyma. Then we talked about secondary spontaneous pneumothorax, a type of pneumothorax in which is secondary to an underlying lung disease. These underlying lung diseases generally can be classified as obstructive lung diseases and destructive and cavitary diseases. Remember, we will have a lecture separately about obstructive lung diseases and restrictive lung diseases. For a while, I'm just putting these two words. Destructive lung diseases, obstructive lung diseases like emphysema and chronic bronchitis, which are also called COPD, asthma and bronchiectasis. All of these conditions, when there is obstructive element, air is during expiration, there is more severe obstruction and intraalveolar pressure may go up, which may rupture and lead to pneumothorax. Then we were talking about destructive and cavitary lesions, right? And these lesions in the lungs, maybe on one side they are connected with the airway, other side they may leak into pleura or communicate with the interstitium of the lung, right? And then produce pneumothorax. Most important is, you must remember tuberculosis, right? Here in obstructive lung diseases, most common you should remember emphysema. So tuberculosis, then necrotizing pneumonias, what is this? Pneumocystis pneumonia, lung abscesses, or cystic fibrosis, or pulmonary infarctions, or carcinomas. All of them increases the risk of what? Yes. And now we go to the, okay, let's have a break, right? After that we'll continue and we'll talk about traumatic pneumothorax, then we'll go to the types of pneumothorax, and then we'll go to the complications of pneumothorax. Most life-threatening complication of pneumothorax is tension pneumothorax, which we shall discuss in detail later. Let's have a